Hi everyone, I want to talk about heart failure treatment. Heart failure treatment. Okay, let's go. Before doing anything, when we suspect heart failure based on signs and symptoms, like if you go through my presentation on heart failure signs and symptoms, that will be self-explanatory because I don't need to waste your time repeating the same thing here. Okay, thank you. So, first thing is to position this patient at 45 degrees. Sit up with legs hanging down, if not hypotensive. But if this patient is hypotensive, no. Then, before we say DR.BEN'S, let's quickly go over airways, breathing, and circulation. At the time we're dealing with airway, we're going to look at orifices, the nostril, the ear, the mouth, any foreign body. If we find, we remove. Any secretion, we sanction as it is appropriate. Breathing. What is the respiratory rate? Peripheral cyanosis or central? Chest deformity, moving with the abdomen, any auscultation, breath sounds, what's the rate? Any crackles, likely going to get. Circulatory system, what's the blood pressure, what's the pulse rate saying, fluid in and out, vital signs generally, the temperature, heart sounds, S1, S2, S3, or even S4 when there is left ventricular hypertrophy, particularly in heart failure with preserved ejection fraction, with left ventricular wall stiffness. We're going to pick S4. Okay. Then the next thing is positive airway pressure. I'm going to give CPAP or BiPAP. We should be ready to give oxygen, but we need to know the O2 side. Then we give oxygen as appropriate. Once it's less than 92, we just give the nasal cannula. Well, it depends on the level of the O2 side, please. Yeah. From the left heart failure, with the backflow to the lungs and pulmonary congestion, we need to send that fluid out. And high cylinder diuretic like furosemide, popularly known as LVEF. I'm not an agent of LVEF, just talking about a good medication. So we can give as high as 20 to 200 milligrams intravenously. Morphine, but we have to be very careful, depends on the type of heart failure we're dealing with. If this heart failure is secondary to myocardial infarction with inferior wall myocardial infarction, that is affecting leads 2, 3, and LVEF, we need to be careful with the morphine and beta blockers and nitroglycerin. So we can't just dogmatically give morphine. We check the vital signs very critically, particularly the blood pressure and pulse. So to decrease anxiety and increase venous dilation, morphine will be fine. And I'm okay with 2.5 milligrams intravenously. Nitroglycerin, yes, you check the blood pressure first. And be careful, just like I've said, as per morphine, when it comes to inferior wall myocardial infarction or heart failure with preserved ejection fraction. In fact, it's advisable that you drop the nitroglycerin in this case. And of course, right heart failure. We have to treat associated precipitants like myocardial infarction, arrhythmias, infections, anemia, and so on, particularly if we are dealing with high output heart failure. And of course, anyone with heart failure, we need to look for the cause, please. We will not forget about fluid restriction, telling the patient that it is uncomfortable, but it's going to be helpful to reduce fluid intake to 2 to 3 liters per day. So they're on restriction to 1 to 2 grams per day and elevate the head of the bed. If we're not winning, then this individual has qualified to be in intensive care unit. By that time, bladder catheterization will be done and fluid in and out will be determined and will be weighed daily. You are free to choose from the following medications, but depending on the type of heart failure you are dealing with and the possible causative culprit, the agent of causation, like intravenous nitroprusside, hydralazine per oral, sometimes hydralazine intravenously or infused into the IV infusion could be used in pregnant women. And LVEF, I just talked about that, dopamine infusion, dobutamine infusion, milrinone, but you don't give milrinone when there is hypotension. Carvedilol or metoprolol, there are some conditions where you can't just give them like that. Digoxin is not in all atrial fibrillation that you are free to give digoxin. Ramipril or captopril or perindopril, Vasetan or candesartan, Entresto, sacubitril, Entresto is a combination of sacubitril and Vasetan. I've talked about Entresto a lot during this presentation. You have to check the blood pressure and rule out cardiogenic shock or severe pulmonary edema before you start your carvedilol. I've just said it. It's not a situation you just pump the individual with carvedilol. Carvedilol is very good. Very good now as a beta blocker in treating heart failure. But not in all cases just pump it, no. So we have to be sure that the BP is good. Any cardiogenic shock going on, any severe pulmonary edema, or even this is right heart failure, we have to be careful. Or this is myocardial infarction, inferior wall, leads 2, 3, and AVL. We need to be very careful. Amiodarone or beta blockers or digoxin if there is arrhythmia. But digoxin is not good in some situations as well. Furosemide and metolazone, but remember, furosemide is high ceiling diuretic. It's going to send potassium out, and we're going to be dealing with hypokalemia. Metolazone will do the same, so both will give hypokalemia. But if you have chosen to place this individual on angiotensin converting enzyme inhibitor or beta blockers or angiotensin receptor blockers or spironolactone and eplerenone, all of this will give hyperkalemia. And even if you want to worsen the situation for this affected patient and you place the patient on sulfamethoxazole trimethoprim combined, which is Septra, or some you call Septrin, Septra, whatever you call it, depending on where you are on the surface of the air, you are going to build the potassium for this individual. Remember, spironolactone or eplerenone will do the same. So you are making good selection, making good medications combined together, but watch out. The patient may die from hyperkalemia if you can't monitor this potassium. So we have to monitor potassium level laboratory-wise and of course the EKG. And we should get all of items ready for possible hyperkalemia. Like what? IV fluid and the given sets, insulin, and of course, not in isolation, get the glucose ready, get caseolates, get calcium gluconate, and you might get salbutamol. Warfarin, if atrial fibrillation or left ventricular thrombus on EKG. Warfarin is very good, we welcome it. Advanced treatment could involve resynchronization therapy with a biventricular pacemaker if the left ventricular ejection fraction is less than 5%, or if there's associated persistent symptoms, or you've done everything, you've given all medications at maximum dosage that is workable, yet you're not winning, then call somebody else who could do that for you. Biventricular pacemaker will be good. Okay, you've done everything medically, but you're not winning, and you're having only one option left, that is surgical intervention. Call for the surgery to implant cardiovascular defibrillator, because that will help, like the name defibrillator, to prevent ventricular fibrillation, killing the patient and dying of sudden cardiac death secondary to ventricular fibrillation. Okay, it is very useful when there is high suspicion of acute coronary syndrome or prior myocardial infarction. It is useful when the left ventricular ejection fraction is less than 30%, and prior myocardial infarction, left ventricular assist device or right ventricular assist device. When you're suggesting cardiac transplantation, it's going to take time. So while waiting, and some may not even get it till they pass on, unfortunately, and some will be fortunate to get it. Well, while still waiting, let them put ICD in place and let cardiothoracic surgical unit be informed if the echo has assisted you in picking valvular defects. Let them repair that, because that might be contributing to the heart failure, like aortic stenosis. There's possibility of valvular replacement there, so no big deal. With that, I come to the end of possible interventions in heart failure as per treatment. My next presentation will be on acute decompensated heart failure, because it's not all heart failure that will be decompensating, but if there's decompensation in acute phase, what are we going to do? We'll meet next. Kindly subscribe to my channel so that you can get my presentations immediately they're published. Thank you.